Welcome, everyone. I'm Maureen O'Connor, president of Palo Alto University. Palo Alto University is dedicated to addressing the pressing and emerging issues through research and training in the fields of psychology and counseling, and we are delighted to have you joining us today. A recent American Psychological Association survey found that 84% of Americans reported feeling stress-based emotions in the 2 weeks before the survey was conducted. As disturbing as that figure is, we also know that the mental health crisis in this country disproportionately affects some communities more than others. During the month of May, which is Mental Health Awareness Month, we are examining the issue of eliminating disparities in mental health care, issues that have been exacerbated by the pandemic and by the systemic racism, hate crimes, and violence affecting BIPOC communities. Today's discussion will focus on urgent mental health needs and important approaches to addressing mental health and service disparities, specifically in underserved Asian American and Pacific Islander communities. Joining me for the discussion today are two of PAU's outstanding faculty members. Dr. Joyce Chu is a clinical psychologist and professor in the psychology department at Palo Alto University, or PAU as we call it, where she co-directs the Multicultural Suicide Research Center and directs the diversity and community mental health emphasis in our PhD program. Her work aims to advance culturally congruent services for underserved communities, particularly suicide prevention and management for ethnic minority and LGBTQ populations. She also specializes in Asian American mental health and teaches a doctoral course on mental health disparities. Welcome, Joyce. And Dr. Shreya Vaishnav is an associate professional clinical counselor and a visiting assistant professor in the counseling department at PAU. She has led several research projects on the impact of microaggressions and facilitated workshops on navigating and responding to microaggressions in academia. Her research and clinical work also focus on providing culturally competent services in working with immigrants, refugees, and Asian American and Pacific Islander communities. Welcome. I'd like to start our conversation by examining a little bit of the state of affairs. What is the state of mental health disparities for AAPI communities? Joyce, could you start us off?
Thank you, Dr. O'Connor, for having us here today. It's a great question. What is the state of mental health disparities? A lot, and I'd love to start by just talking about the model minority myth, which has been around for a long time. And a lot of folks, the model minority myth really refers to the idea that Asian Americans have overcome a lot of disparities that other racial and ethnic minority communities experience, a lot owing to a larger percentage of Asian Americans having achieved higher education, that the achievement gap not being as high. But there are a couple issues with the model minority myth. And I'll share a quick slide here. Looking at Asian Americans as a whole really shrouds any subgroup differences between individual Asian American groups. So what you see here is that within the US as a whole, about 32% of individuals have achieved a bachelor degree or higher. And there are certainly some Asian American subgroups that have higher percentages of highly educated individuals, such as in Indian South Asian populations, Chinese American populations. But if you really just focus on Asian Americans as a whole, you miss that there are some subgroups that have not achieved that level of education that disparities do exist, such as Vietnamese, Cambodian, Laotian individuals. So that's just one example. And the way that the model minority myth has an impact on mental health and mental health care disparities specifically is that it gives the impression that Asian Americans are doing fine. There's not as much as an achievement gap. they must be doing fine. And that applies to mental health as well. And so what you see just in policy and in the way that our mental health systems have been set up is that there hasn't been as much attention, particularly to some of the Asian American and Pacific Islander subgroups that actually have higher need because of this erroneous assumption and myth of the model minority. And so when you look at the core of that question, what is the state of mental health disparities? Well, one, there's a historical lack of inclusion of Asian Americans in larger national epidemiological studies, but for the ones that are available, some of them actually show either no difference overall in mental health prevalence rates or slightly lower. However, we don't have a lot of advances in understanding what are the effects of the assessment instruments that we use, and we may not have culturally valid assessment instruments, and we haven't really quantified just different cultural tendencies in how we answer questions when somebody asks you about depression. And we have some evidence to show that there are some reporting tendencies of either interpreting questions more or less. And so we don't have these culturally valid instruments to know whether or not those disparities and some of those rates showing lower prevalence rates are true differences. However, by and large, experts have really concluded that there are no huge prevalence differences. Now, if you actually then break it down by groups, because we don't want to look at Asian Americans and Pacific Islanders as a whole, you actually said that there are some subgroup differences, like greater PTSD in Southeast Asian refugees, which is a very underserved population, Pacific Islander individuals and also Asian American older adults having higher suicide rates, deaths by suicide. And so we really need to break that down to really understand what really is going on there. And really the largest issue is in service utilization and what we call mental health care disparities. It's a pretty stubborn disparity, and I'll happy to show a couple of slides here. So if you look at use of mental health services in the past year amongst all different US adults, what you see is that Asian Americans, even after controlling for any differences, small differences in prevalence of mental illness, AAPI adults seek mental health services less than pretty much any other racial ethnic group in the United States. And in fact, it's almost as like 3 times less likely than white adults to be seeking mental health services for unmet needs. So this is for anybody with a mental illness. And this lower service use applies across a different variety of types of mental health services. So what you'll see here is that, with medications, which is this second bar, or with outpatient services, which is the lighter blue bar, or inpatient service use, orange, what you'll see is that the Asian American individuals in this cluster over here, across the board in different types of service, you'll see that they are using services less. And that's particularly concerning when you look at just different trending increases in suicidal thoughts and plans and attempts, with this being a significant difference. For example, in 2009 versus 2019, Asian American, Native Hawaiian, Pacific Islander adults, 26 to 49, being significantly more likely to be making a suicide plan. So there are issues that we really need to be aware of, in particular, this service utilization. And this is a really long-standing problem that I think, really deserves more discussion. Not only are Asian Americans not connecting with services initially, but they're also dropping out of treatment earlier than other individuals. And they're also waiting longer to seek treatment, so that when they're actually seeking treatment, what they're dealing with is just much more severe. So ideally, we really want to get people a little earlier so we can do better prevention and prevent more suffering.
Thank you so much for sharing that, because I think several thoughts come to my mind. One is the importance of really good research on these issues, right? Because if we just look at numbers without really understanding how the surveys are being done and what definitions are being used, et cetera, we are really going to miss some things. We're also going to miss some things if we don't have culturally competent instruments, as you've pointed out. So really important foundational work. And I'd love to turn now to you, Shreya, and sort of follow up a little bit by asking, why, aside from the sort of concerns about people in general, obviously we care about people's well-being, but why do we need to pay particular attention to these mental health disparities now?
Yeah, thank you, Dr. O'Connor. In addition to what my colleague, Dr. Chu, has also already mentioned, I'll highlight a few more things that might highlight why it's important to pay attention to these things at this moment. So we know that historically there's been an erasure of AAPI voices that contributes to mental health experiences in the community. This comes from experiences of discrimination and just immigration experiences of folks who belong to this community. We also know that AAPI individuals are less likely to access mental health services than any other racial group, partly because of the cultural bias against mental health services, but also, as my colleague mentioned, due to lack of culturally relevant approaches to treatment. And something that was also already mentioned was that AAPIs are 3 times less likely to seek mental health support than their white counterparts, which is a large number there, right? 3 times less likely. And then model minority myth adds to the stigma. The notion that AAPIs are model minorities places them on a pedestal, and that there's a pressure to fit the stereotype, to be perceived as having it all together, not needing help. And however, this is a myth that we're all doing fine in the community. So while there were a few stats that were highlighted as it relates to the AAPI community, I kind of wanted to highlight a few more as it relates to COVID-19's impact on AAPI communities. So here's what we know so far. We know that Asian Americans and Pacific Islander groups have a high % of cases and deaths as it relates to COVID-19. In fact, it's 10% higher in California than a lot of other states, which is alarming in itself, and important for us to know as we are considering working with this community and thinking about how we provide services. Asian Americans and Pacific Islanders were also most impacted by the unemployment spike last year. The increase in unemployment spike was about 450%, which is a lot, right? So a lot of folks lost jobs because of COVID-19. And then, of course, the increase in hate crimes as a result. We know that there's been a 149% rise over the previous year as it relates to hate crimes towards Asian American and Pacific Islander communities. And this is through overt racism, subtle racism in the form of microaggressions. We know that AAPI communities are often treated as second-class citizens. They're treated as perpetual foreigners. They're seen often, they're not seen. They're considered invisible, and we associate AAPIs as a monolithic community, which is problematic because, just like my colleague mentioned, there are so many between group and within group differences that we need to consider as we look at mental health disparities. And then we know that there's been, lots of reported episodes related to verbal harassment, insults, jokes, physical assault. There's killings that's happened of late, referring to COVID-19 as Kung flu or China virus, has all impacted the mental health for Asian American and Pacific Islanders, especially in the last year and a half. And this, in general, has led to a low turnout at vaccination sites due to fear of their well-being, fear of what's going to happen to them if they leave their home, fear of being viewed as second-class citizens, being the victim of hate crimes. And so there's been overall a more increase in underutilization of medical and therapy services. And so that's something that has been increased by a lot due to the pandemic and the current state of affairs.
So it's clear that we have an issue. We have an issue with mental health care disparities. And it preceded the pandemic, is what I'm hearing you both very clearly say, but has then been exacerbated by it, right? So we're in a position now where we know we have to do something. But there must have been some attention to this prior to this time, prior to the pandemic. So let's turn our attention to talking a little bit about what has been done previously to address these mental health care disparities.
Yeah, there have been a lot of efforts to address these disparities, really at all levels of the system. We call, when in psychology, we talk about the ecological system, which is, looking at both everything from global policy to the individual level. And there have been people and attention at all levels to really create a comprehensive system of outreach, of care. And a lot of work has been done to just make mental health awareness more present and different service options to be tailored to the needs of the AAPI community. It really actually started increasing in attention back in around 2001, where we had the Surgeon General's report from the Department of Health and Human Services. Really was the first huge seminal report to establish the fact that these disparities do exist, and it really kickstarted the work. I would actually say a lot of funding, a lot of attention, a lot of efforts went into looking at mental health disparities and for AAPI communities in particular. And I think we need to continue that funding and that support. There have been times when some of that funding has decreased, and that's something that we really want to keep the gas pedal on, because these are disparities that are in the making. As we just discussed, these are lifetime disparities that we are living with, and that that are being created anew. There are wonderful efforts that have been put forward, like educating all providers, mental health care providers, around the importance of cultural humility and general kind of the journey towards addressing culture within our work. At the community and public health level, a lot of anti-stigma efforts within campaigns or community trainings in media efforts. There's also been a huge effort to make sure that everybody who speaks a non-English language as their primary language has access to services. We have a long way to go there, but we are living in the Bay Area. Some of you may be watching outside the Bay Area, but for example, in the Bay Area, we have places like the Asian Americans for Community Involvement, which is a community-based organization that offers services, mental health services in many different languages, or Richmond area multi-services in San Francisco. So all of those ethnic match services, we know that if somebody has a preference for an ethnically matched provider, that if they are offered that match, they're going to be more likely to stay in treatment in the early phases rather than drop out. So that is really important. There's also an entire field of really amazing work looking at the fact that, hey, we have evidence-based psychotherapies and interventions that have been developed and invalidated on mostly white, heterosexual, cisgender individuals, and that we need to have treatments that are equitably evidence-based and available to AAPI individuals. And we haven't historically had that. And so really within the last 14, 15 years, there's been a whole body of work trying to make sure that we know how to adapt and infuse those treatments with the cultural considerations for AAPI folks. And so, all of those efforts, I think there's a lot more work to be done, but we are in a really, wonderful place and having a solid foundation of a lot of that thinking already done. And I'd love to talk about ideas for, where do we need to go next also.
And I know that you and your students have done a lot of that important work, and but as you say, not nearly enough. We need to keep going. Dr. Vaishnav, do you have some thoughts about this issue of sort of what's been done and what did it look like?
I think something we need to look at has also been within the AAPI communities. Often the older generations may use unhealthy forms of coping that have been passed down to younger generation, right? Which could look like ignore the racist attacks or work harder, keep your head down, which again ties to the model minority myth, right? That the idea that we're models of society and don't require help or assistance. However, some of you might have heard of Stop AAPI Hate, but it's an organization that's really leading community efforts in collecting data on hate crimes in the AAPI community. And this data has been able to create more visibility and sense of urgency within our communities regarding what's going on, and that this is important work we need to address. This needs to be talked about, and we need to support people experiencing the impact from COVID-19, from the pandemic, but also hate crimes and just vicarious trauma, right? That can come up because they're hearing about people in their community being impacted. So I think what's happened is of late, AAPI communities are experiencing and recognizing the traumas of feeling culturally and emotionally invisible, feeling like they do not belong and are perpetual foreigners. And this has created an increase in awareness for the need for healing and more awareness for mental health disparities for AAPI groups. So there's been movement in the area, and of course, there still needs to be a lot more work that needs to be done in creating or narrowing that gap in mental health disparities within our communities.
Yeah, you mentioned vicarious trauma and trauma-informed care and things along those lines. We can do I'd love to do another whole session on that, because I think that's really important point that you've made, that this isn't just about, what happens to me, right? It's also what I hear about that happens to those in my community, what I see on the news, what's happening to my grandparents or my grandchildren or whoever. And those are really important and distressing events as well. And so it's not just individual approach here. This really does require focusing on the community. So that's really, really helpful. Well, let's not dwell on the past here and what we know. Some work has been done. We also know more needs to be done, and so let's spend some time now focusing on what more can be done to address these important issues. Let's start, Dr. Vaishnav, with you talking about, are there any gaps in our previous efforts to address disparities? Or maybe Dr. Chu, I'm not sure which one of you wants to take this first, but what innovations are needed in the future to address disparities? And I'd love to get both of you thinking about this.
I'll talk more in reference to medical and clinical settings, and for communities and allies, what we can do. And then I'll have Dr. Chu go take it from there. But one of the things that, we've noticed being in this field is that we need to connect research to practice. There's a lot of important research out there. There are a lot of important stats and information that's being researched by scholars. However, it's not being translated into practice. There are different consumers here, right? So we need to think about ways that we can really consume the research, but also pass it on to the communities who are actually the ones being impacted, and to organizations who are supporting the communities. So that's something that we want to think about and explore in terms of what we can do moving forward. In terms of the clinical setting, as a counselor in private practice, I've definitely received an increased number of calls for working on trauma and fear as a result of anti-Asian hate crimes. And I know a lot of other therapists have been feeling the same pressure, right? That there's a lot of need and support that needs to be given, and it's something that's increasing as the hate crimes are increasing, and as folks are really experiencing the trauma from not just directly experiencing hate crimes, but also vicariously through the community. Everyone just needs healing, right? So what we do know, and this is something Dr. Chu mentioned earlier, is that there is an underutilization of services. We know that in general, people of color have a higher premature termination rate, which is 50%, as compared to their white counterparts. And this is probably due to experiences of cultural insensitivity, right? When there's a mismatch, when the therapist or the provider are not able to cater to your client's cultural needs. So it's important that in therapy and medical settings that we practice cultural competence, approach our work with cultural humility, and think about broaching, which is essentially using understanding the socio-political climate and exploring the cultural identities between you and your client or your patient, and really talking more about not just the similarities, but also differences, right? And how might this inform the work that you may do with your client or patient in the future? So it's important to continue bringing in identities and the socio-political climate as it impacts our clients and patients, because this is the kind of discussion and conversation that will help folks in the AAPI community to feel comfortable and open up to providers, to therapists, to talk more about what's going on for them. It's important not to treat AAPIs as a monolithic group, right? We have over 20 groups under the AAPI umbrella, and there are so many differences and similarities, right? But I think the mistake that often folks can make is put everyone in together and then stereotype the group. So it's important to even explore our clients and patients individually and understand who they are and what their experiences have been, because they might be different from what you've assumed a certain group's experience will be, right? And then addressing signs of racial trauma. Racial trauma can lead to long-term depression, anxiety, somatic symptoms. We know this from research, right? So it's important to look for signs for racial trauma and address it as they come up in our clients. And then considering outreach efforts, offering support groups, psychoeducation, especially because of the hesitancy in general and the stigma around one-on-one therapy, it might be helpful to instead focus on outreach and using different platforms through organizations to create more of an awareness and understanding of what therapy looks like, what mental health support can look like. And then a couple things with allies, community members. It's important to just overall raise awareness. So something that I like to say is when you see something, you say something, right? Make the invisible visible. Because when we're able to intervene as bystanders, when we see something around us that's happening that's unfair, that will help and support the victims, right, of hate crimes, and can empower victims to speak up, to seek the support, and know that they're not alone, that what they experienced is not an isolated incident, or it's not something that they're making up or it's in their head.
That's great. And I love that, from the standpoint of our university setting, what you really are talking about is important considerations in how mental health professionals are trained, right? This is really important, and we can't necessarily do things the way we've done them if we're going to address this full range of issues. So that's terrific. And Dr. Chu, I know you have a lot of thoughts on this. I know you'd like to look forward. So let's hear from you on this.
Yeah, well, I'd love to comment just on a couple of things that both of you already said, in particular about the impact of racial trauma. As I think, just like everything, we need to understand psychological concepts and experiences within the context, right? And I think experiences of racial trauma are deserve particular understanding for a lot of Asian American communities who are more collectivistic, right? So in our fields, we have something that are called an interdependent self-way, that the way that I understand myself is actually including my family members, my loved ones, my friends. And so if my friend or my loved one is hurting or is hurt, that actually hurts me in a way that actually is an infliction upon myself. And so when you have this kind of collective consciousness and you start to see, and Dr. O'Connor, as you were talking about vicarious trauma, and you see a community member being hurt or traumatized or being a victim of violence, that affects your self-identity in a way that is a totally different context than if I were to have an independent self-way, which is me as a kind of an encapsulated individual. And so these are things that we need to understand more. What does it mean to have a collectivistic, interdependent self-way and have racial trauma? Also in the context of of having cultural values and practices about taking, not burdening others and keeping things to yourself. And yet we're living in a culture where very much, we need to raise more awareness and attention and be a little loud around, not more, more than a little loud, of getting attention to these issues. And so I think a lot of, there's just so much more attention and support needed around the fact that there are a lot of AAPI community members that maybe, are kind of stuck and in a place where, there is maybe a lot that's being hidden and a lot more services that are being needed. So that just kind of came to mind when you were all talking about trauma. I also resonated a lot with what Dr. Vaishnav said around, the need for research to be translated into practice. People have done research on how long it takes for research to be translated into practice, and it's something like 18 to 20 years, which is way too long. And we have had a lot of advances recently to try to speed that up, and we need that to happen. We call that translational research, where you translate basic research into practice and application. And we need more supports within our academic systems, within our funding agencies, to fund that kind of research and to support that kind of work. And at PAU, conveniently, that is actually that's one of the reasons why I am a faculty member at PAU, is that we do that kind of research. And so, there are so many, innovations and ideas in the research that I think when you look forward, we really need to act on. And it requires systems supporting that work in order to act on it. We've known about these disparities in service utilization since 2001. It's been 20 years, and the data doesn't look like we have made an appreciable dent. At the same time, these disparities are, like I said, are in the making. So there's a little bit of a race there, right? But we need more funding. Like, if folks out there, if you're in a position to donate to Asian American serving organizations, this is the time to do it, to give more support and grant funding to Asian AAPI research, mental health research. We need it, absolutely. So that's a little bit on a soapbox here. But I also think there's really important needs for innovations around the specific point in this process of help seeking, of getting people to the help they need. And I am not presumptuous to say that specialty mental health is the end all be all. You don't need to end up in Dr. Vaishnav's office or mine. There are lots of ways of getting support, but we don't want people to be suffering in silence. And there are a lot of ideas. There's some new research that looks at what I call, quote unquote, stalls in the help-seeking pathway. There's emerging work to know that when AAPI individuals, when they actually mention that they're in distress to somebody else, this could be a friend, a family member, they're less likely to be encouraged by that one person that they reach out to get the help that they need. And they're also less likely to have role models in their immediate life that have sought help before. So it's this idea that there's so much that we can do as community members when somebody talks to you or talks to me, and in my role as a friend or a loved one or a family member, oftentimes I'm going to be the only person that person reaches out to. And it's so important for me to role model, like, hey, thank you for talking to me. It's okay, let's get you the help. And modeling that can make all of the difference for somebody who otherwise would have that one reach out and then stop. Also looking at our organizational systems. We've done, like I mentioned, a lot of work on developing culturally infused and adapted treatments, but what about that point of initial contact? Like when I make that phone call, or if I go to a primary care provider or my religious leader, which we know AAPI folks are more likely to do that, what message am I getting? How am I given a referral number, right? So it's like, oh, you should seek help. Here's a phone number. Is that good enough to give me a phone number on a piece of paper? We did some preliminary work that we never got to publish that the biggest predictor of when somebody seeks help is when the person who's giving you that number actually sits down with you, like a primary care provider, and sits down and calls with you in the room or gives you a brochure rather than just mentioning a resource. And there's so much work that maybe we can do in that whole referral process when stigma is high for AAPI folks. Maybe that is where we can really innovate. And how does somebody on the other end of the line pick up the phone? What does that interaction look like when somebody's so reluctant, and it's such an amazing thing that they picked up the phone? How should those phone calls be managed? And I don't think we have enough of that kind of work.
That's amazing. I mean, that's my theory of, instead of going to primary care doctors, we should be going to mental health professionals who then refer people out, right? Because it's, if it were that much, if it was seen in that way, right, that everybody has some challenges and let's just figure out which ones we need to work with, as opposed to those other people who have problems, right? And I think that's a really, really helpful. It sounds like work that needs to be done.
Absolutely. And the more, there's a term that we have in the field called mental health literacy. And the more that we increase our mental health literacy in the community, the more likely people will be able to open up and get support. And there are some really cool efforts out there of people making skits to really model, how do you actually talk about mental health issues to youth and things like that.
And you've both sort of touched on this a little bit, but are there some specific subgroups or issues that need our attention? We can again do probably a whole other session on this, but might you want to mention a little bit about that? I think that's an important topic.
When you talk about intersectional stress, so Dr. Vaishnav talked about the fact that there's more hate crimes within the AAPI community this year in 2020. And the data really supports how much that has increased. When you look at that stress and you think about what we call intersectional identities, which is more than one cultural minority identity, we look at AAPI LGBTQ plus individuals, so gender sexual minority individuals who are also AAPI. And there is absolutely more need for resources and attention towards that subpopulation, because there's potentially what we call a double jeopardy, where the AAPI LGBTQ plus folks are experiencing marginalization and discrimination, both from mainstream society and also from within the AAPI community towards LGBTQ folks, and within the LGBTQ community towards people of color and BIPOC communities and AAPI individuals. And so we have some research to show that unique stress of that intersectional stress and trauma can be particularly heightened. And that's one group that I think we really need to think about supporting a bit more. And also AAPI youth and elderly females in particular are also two populations that I would pay attention to with regards to suicide. So there's been a lot of conversation around, some of the I guess the junctures of not getting the help that they need, plus unique cultural stresses, meeting together for a lot of AAPI youth, of a lot of maybe academic expectations and pressures, a lot of meaning around some of the acculturation stresses or family and cultural kind of conflicts that they're dealing with, that can often be linked with increased suicide risk. And so I would definitely want more attention for those subpopulations as well.
I completely agree with that. And, the research supports that in terms of just the higher rate of suicide, and then also just focusing on AAPI youth and LGBTQ plus IA communities, and paying special attention to intersectionality when working with folks from AAPI communities, because the intersecting identities add levels of complexities, right, to an individual's experience and what's going on for them. So understanding what are the different unique and salient identities that a client brings in, and how do they view the world from their perspective, and what's going on for them as it relates to their different identities. Another population that has been a concern for me, and it's something I've been thinking about in my private practice as well, is South Asians, especially right now with COVID-19 and the impact in India with, everyone who live here, right, in the Bay Area, in the US, have a lot of family, friends, relatives who are back in India. And there have been so many COVID positive cases and deaths that's led to a lot of trauma, collective trauma. And that community needs a lot of support right now. However, you add the complexity of hesitancy for seeking support, right? Not knowing whom to reach out to for support. So even keeping that population in mind in terms of how do we cater our outreach efforts to normalize mental health support and to validate these experiences. So when clients call us, when patients call us, that 20-minute consult or initial phone call, as Dr. Chu mentioned, is super important, right? How can you normalize this experience, but in a way also add that this is hard, and this is something that that is going to impact your life or is impacting your life. So let's talk about it, and let's really support you in getting to a place you want to be, that can feel comfortable and fulfilling for you.
That's really, really helpful information. So we are drawing to a close of our time here, which is, I could talk with you both about these issues for much longer. But I'd like to ask each of you for some final thoughts, maybe tips or suggestions for, resources where we're pointing people toward help of the type you're talking about today.
Something I can share is maybe tips for when looking for a therapist. It's, even to start looking for a therapist can be very daunting and scary and anxiety inducing for a lot of people. So it's important to even talk about the process and understand what happens, right? What should I expect when I'm trying to look for a therapist? So a few things that I'd like to say about it is it's, shop around, find the right fit. There are a lot of therapists out there who have different specialties and different experiences. So it's important to reach out to multiple people, and talk to them to understand what their style is and how does that fit with what you experiencing and what support you need. Take advantage of free phone consults that many therapists offer. So therapists in the community offer 20-minute free consults that you can have with them. You can email them, reach out to them. Psychology Today is a really helpful resource for finding therapists in your area. And plus, because of a lot of things being telehealth now, you also probably have options to reach out to therapists within the state, right? They don't have to be in your locality or community. You can do video sessions with them, which makes things really convenient. But when you're having this phone consult, ask questions like their familiarity with your culture, or whether the therapist could tailor treatment to your specific cultural experiences and identities, or even the therapist's thoughts on what's going on in the socio-political climate as it relates to the trauma, the hate crimes, or whatever else that's coming up for you, right? So it's important that you find a therapist who's able to view things from your perspective, your lens, the different intersecting identities you bring into the room. So it's as important for you to shop around for a therapist than just finding one and sticking with it. And then also knowing that it takes time. Therapy takes time, and the first few sessions might just be getting to know each other and really exploring what the concerns are, but giving it some time to understand whether this is a good fit, whether this is working, before thinking about switching therapists or choosing to leave. So those are some things that come to mind when I think about tips for what you could do when looking for a therapist in the community. Dr. Chu, you can add more. If I've missed out, I'm sure I missed out a few things out from there, but feel free to add more to what I just.
Yeah, I would echo everything that you just said. And also just encourage folks, if things aren't feeling right, therapists, we're all trained to have those conversations, and we won't, those are the conversations. We want to hear your feedback, and we ultimately are here to really play a role in getting you connected with the person that is the best fit for you, including if that doesn't include us. And so, no therapist wants their client to stay with the therapist longer than they need to, or to not feel comfortable speaking up. And so, all of those tips around, really asking the questions that you need and et cetera, are so important and just part of the process. And we're all used to it. So, no need to tiptoe around it. Just, get in there for sure. I would just also add, any last tips is it would be great for all of us to really be those community eyes and ears. So if you see somebody in your life that you suspect is struggling, it's really nice to assume that, hey, maybe they want someone to talk to, or is there a way for me to support them in the way that they want to be supported? I had my immigrant Chinese American grandpa, whenever he was troubled, he didn't want to talk about it, but me sitting there in silence right next to him, I know did a lot, right? And that was his way of needing support. And so I did that with him. So, really listening to what our loved ones need, but also not being afraid to say like, hey, a lot of people, especially when these stresses are just so high, and really normalizing that, a lot of people find it useful to talk to someone. Have you thought about that? And can I help you do some research and find that, options for you? And really just increasing our mental health literacy across the board. So the more that these conversations about mental health can be part of our everyday lives, the more that some of these disparities will be addressed. So I just encourage all of us to kind of play a role in there. I also have a slide with some specific AAPI resources, and I think at PAU we also have a place where we have a longer list of resources, but I just wanted to show this because there are a few resources in here that specifically list AAPI identifying or allied therapists, like the Asian Mental Health Collective, I believe the South Asian Mental Health Initiative and Network. And so would love to show that to you all. Also, it's just important on the bottom here, if you or someone you know is in a mental health crisis, please know that there's the National Suicide Prevention Lifeline, which is 1-800-273-TALK, TALK, that you can call 24/7. And also the crisis text line for anyone who prefers to text, that's also available 24/7 and available free of charge. If you're ever in a crisis, it's really important to know that you can reach out to someone, right on the moment.
Thank you so much for those resources, Dr. Chu, Dr. Vaishnav. This has been a fantastic discussion of important issues around mental health disparities, and the importance of educating the entire community, all of us, to be better and better educated about these issues so that we all get the help that we need when we need it. So thank you all for joining us today. Thank you to our panelists for this very informative discussion. You'll be able to find this discussion and others in our series on PAU's YouTube channel. Thank you all very much. Wishing you all the best.
Thank you.
Thank you.